Hi, my name is Michael Ritchie. We're going to be talking about right heart failure. Our objectives are going to be talking about right heart hemodynamics, recognizing right heart problems, differentiating right heart failure, treating right heart failure, and then preventing right heart failure. I do want to focus on recognizing and treating right heart failure because I think it makes a big difference, especially in the ICU, is being able to recognize it and then do things that are going to be able to treat it to be able to stabilize your patient. I'm going to go over some learning concepts. These learning concepts are going to be pericardial compartment syndrome, renal venous congestion, and then looking at organ congestion with pulsatility. And I think these will bring about concepts that will make it easier to understand why we're doing the things that we're doing. I always talk about right heart failure as being the ignored or untaught heart failure. There's so much time spent on the left heart that the right heart often gets ignored. Whenever I was being taught about right heart failure, whenever I was in residency, they always were like, oh, there's not much to it. It's super easy. You're just going to do a right-sided EKG. You're going to give them a bunch of fluids. I've learned since then that that is actually not the way you should be treating it and can cause a lot of problems down the road. The next question, though, is who cares? Like, why does it matter? Why do we need to focus on right heart failure? It's not as significant as the left heart. It only accounts for about 3 to 9% of acute heart failure exacerbations, but the in-hospital mortality is similar to that of left heart failure. So it still has a high mortality rate. It's just not as frequent. The first thing we're going to talk about is the right heart hemodynamics. So cardiac output is broken down as heart rate times stroke volume. Stroke volume is further broken down into preload, contractility, and afterload. Preload is usually looked at as the venous return of the blood going to the heart, and it's the end diastolic volume before systole. Contractility is the RV function. It's a little bit harder to look at with the RV compared to the LV. And then the afterload is going to be the pulmonary vasculature or the pulmonary vascular resistance that we'll look at. The right heart has a Starling curve just like the left heart. I don't know exactly what it looks like, but the idea is that as you give the RV more volume, it's going to stretch the RV. That's going to put it higher up on the Starling curve until a point. There will be a point where you actually plateau out, just like the Starling curve on the left heart, where it's no longer going to increase the cardiac output as you increase filling, and you're going to end up with complications. There's this misnomer that the right heart loves fluid. People love to talk about that. And it's true that the right heart handles fluid better than the left heart, but it doesn't mean that it loves fluid. And in a lot of situations, fluid can be bad. But what we get this from is, in this study, what they looked at was they looked at how much the ventricle stroke work was as they added more and more preload. And the right ventricle did very little extra work. It's thin, it's hanging out on the side, it's designed to stretch, it's designed to handle preload. As opposed to the left ventricle is big and thick. It's not designed to relax and let in a lot of preload. So the RV handles preload way better than the LV. If you look at the RV from an afterload standpoint, you can see that the right atrium pressures are 0 to 5 on average. You're looking at the right ventricle pressures 25/5, and then the pulmonary artery, or the pressure that it pushes against, at 25/12. This is significantly different than the left ventricle, which is 120/15, and it's pushing against an aortic pressure of 120/70. So it's having to push against significantly higher pressures. Whenever we look at the actual resistance that they have to go against, or the afterload, the pulmonary vascular resistance compared to the systemic vascular resistance is that it is almost 10 times higher on the left ventricle than it is on the right ventricle. The right ventricle is not designed to push against anything. It's designed to just go right from the right heart straight across the left heart without having to go against a lot of pressure. If it does go against pressure, then that's where you end up with complications. Here's an example where we look at the right heart versus the left heart in terms of afterload. And this is the opposite. Because the left ventricle is so big and thick, it's designed to push against that higher pressure. So the right ventricle, it's thin, it's sitting on the side, it's not designed to push against that pressure. So if you add afterload to the right heart, you get a significant reduction in the amount of stroke volume. It'll drop down to 70% with very little changes in afterload, whereas on the left ventricular side, you can have huge changes in your afterload with very little changes in stroke volume. So the right ventricle does not like afterload. And here's a good example of looking at the right ventricle compared to the left ventricle. It's thinner, it hangs out on the side, it's just a free wall compared to the LV, which is big and thick. And if you actually look, it has more longitudinal fibers than fibers that are going to cause circumferential squeezing. So its contractility is actually more in a downward motion as opposed to an inward motion because it's just a free wall that hangs out on the side. So why is the right heart so difficult to diagnose whenever it comes to failure? Like oftentimes it's missed, it's attributed to something else. You don't realize that they're in right heart failure until further down the road. And I think one of the reasons is that everyone attributes the rails, the hearing those crackles in the bases, seeing that pulmonary edema on the x-ray. Like people are so used to saying, all right, they have this, they must have heart failure. Well, in right heart failure, you're not necessarily going to have that. And so because you have all the other symptoms of heart failure without the pulmonary edema, it often gets missed. They'll have lower extremity edema like you see here, but whenever you see it, what happens is they'll say, oh, they have chronic venous stasis, or oh, they have chronic lymphedema, or they have something with the way that their blood goes back to their heart, as opposed to recognizing that they're in right heart failure. Oftentimes what you'll miss is people will have other diseases. They'll get right heart failure, but it'll kind of mask that edema that you're used to seeing. You're used to seeing that bilateral lower extremity edema. Some people will carry a lot of the fluid in their abdomens, or they'll have these very high pressures and all these failure in their right heart, but it won't necessarily show as the edema that we're used to seeing regularly. Here's another example. Patients that are morbidly obese, they often hide the extra fluid that's being put on. They're hiding a lot of those right heart failure symptoms. Now we're going to look at a couple of echoes. Oftentimes, whenever I ask somebody to say, hey, you know, what does the heart look like on echo? They'll say, oh, the EF is fine. And then they'll want to move on. And there's just so much more to understanding what's going on in an echo. And I hope that you can take away from this is just taking that little bit of extra time and looking and saying, all right, there's more to how the heart functions than whether or not they have a good EF. In this example, you could easily say, oh, the EF's greater than 70%. Let's move on. Here's a case 2 where it talks about the first 2 lines show, hey, the EF is normal, the EF is 60%. People will say, oh, everything looks good. This person's low blood pressure, this person's problems must be related to something that's not the heart because the EF is normal and it says everything looks good. Here's another example. The left ventricle is normal in size. The EF is normal, 60 to 65%. Oftentimes you could kind of miss what's going on if you stopped there. Now, the next part we're going to do is kind of differentiating the types of heart failure so you can get a better understanding of what's going on so you can treat them better. There's 3 different types and it's based on the stroke volume. So we talked about stroke volume being broken down into preload, contractility, and afterload. So the 3 types of heart failure are preload, contractility, and afterload problems. Preload problems are pretty rare. They're due to volume overload as the primary problem. You're not really going to see that in the adult population. It's seen more in children with large ASDs or VSDs. Usually they'll get volume overload, but they'll get volume overload because they also have a primary contractility or afterload problem. Contractility issues is going to be due to RV failure with normal afterload, and then an afterload problem will be RV failure due to high afterload. So here's the example of the RV failure due to increased preload. Again, it's not very common. It's not really seen in adults, so we're not going to spend a lot of time on it. Here's RV failure with normal afterload, so a contractility problem. the most common by far for this would be due to an RV infarct. So here's an example of an EKG. You see ST elevations in 2, 3, and AVF. In order to determine that this would be a right-sided infarct, oftentimes you would do a right-sided EKG. Your right-sided EKG, if you see ST elevations in V4R, then that's going to be significant for saying that you have a right ventricular infarct. Now, the third one, or RV failure due to increased afterload, that is by far the most common because it is such a common endpoint to so many diseases that we see on a regular basis. And that is where they get pulmonary hypertension. So whatever chronic disease they have, they end up with pulmonary hypertension. The pulmonary hypertension causes a significant increase in afterload, and that the right heart won't handle. And then as it has to handle the higher and higher pressures, it starts to fail. The increase in afterload can either be due to systemic responses or interventions, or it can be secondary to acute or chronic diseases like we talked about before. Systemic responses, what we can look at is the pH. So if your pH goes from 7.4 to 7.1, or if you get hypoxic and the PaO2 drops, their PVR can go up by 200, 300, 400% just by being acidotic and hypoxic. So in these patients that are susceptible to RV failure, you do not want them to be hypoxic or acidotic, because it's going to cause a whole lot of problems that you don't need. It's going to worsen all this pulmonary vascular resistance. There are patients that used to talk about ARDS where they would say, hey, I want to keep them in like a permissive hypercapnia because that's what's going to help out from an ARDS standpoint. But it's actually going to worsen this on your right ventricular function because it's going to increase that pulmonary vascular resistance. It's going to make it harder for the RV to go to the LV. Positive pressure, right? That's very common. They say, oh, we don't want to put a lot of positive pressure on this person because the positive pressure is going to increase your pulmonary vascular resistance. And that is true. If you put positive pressure on somebody, you're going to distend that alveoli. If it's over distended, it's going to put pressure on the capillaries. It's going to increase the pulmonary vascular resistance. But if you under-PEEP them, if you don't have enough positive pressure and they have a lot of atelectasis, the body's response to atelectasis is to squeeze down those arteries and capillaries that are going to the areas of atelectasis because it doesn't want to send blood to areas that aren't getting oxygen. So if you have a lot of atelectasis, you're also going to increase your pulmonary vascular resistance. So you can see this U shape whenever you're looking at pulmonary vascular resistance versus lung volume, is that if you under-PEEP them, they're going to end up with atelectasis and increased PVR. If you over-PEEP them, they're going to end up with over-distension and increase in PVR. So these people can be very complicated because you want them to have the exact right amount of positive pressure to optimize their pulmonary vascular resistance. The diseases that we talked about as a common endpoint for high afterload situations is broken down into pulmonary hypertension groups 1 through 5. There's PAH, which is group 1. There's left heart, group 2. Group 3 is lung. Group 4 is CTEPH, or chronic thromboembolic pulmonary hypertension. And then group 5 is miscellaneous. I'm not going to spend a lot of time on these. I just wanted to list them out to show how common these diseases are that you see every day. So group 1 actually has portal hypertension if you're cirrhotic, HIV, connective tissue diseases, drugs and toxins, specifically methamphetamines is very common. And these are patients that you see regularly. Obviously, you're going to see people with left heart disease for group 2, and then group 3, lung disease, a lot of COPD, a lot of obesity, hypoventilation, obstructive sleep apnea are very common in these patients that you see. So you're going to have a lot of patients that end up with pulmonary hypertension down the road. Group 4, CTEPH, you can see is an example of what they pulled out of somebody when they did an embolectomy. But you have all of this chronic clot that's just sitting in that pulmonary vasculature, and it's making that resistance very high, and it makes it very difficult for the RV to push blood over to the LV. And then group 5 is miscellaneous, including chronic renal failure. So there's just so many diseases where the endpoint is pulmonary hypertension, and just be aware of it and look for it, and just know that if someone's not doing well all of a sudden, is pay attention to their pulmonary pressures. Are they getting pulmonary hypertension due to their chronic disease? All right, so that's by far the most common, and so we're going to focus on that as we go down the road. Pathophysiology. Why is right heart failure so important? What happens with it? This is called the death spiral. This was described whenever dealing with acute PEs, but even people that get into decompensated right heart failure due to high afterload, they're going to have the same issue. So the RV dilates. When the RV dilates, you get worsening tricuspid regurg. This also dilation puts tension on that thin RV wall. What that leads to is increase in oxygen demand because it's having to work harder. You have ischemia because of that wall stress. You have decreased contractility because you're overstretching that Starling curve. That's going to decrease the RV output. Decreased RV output means there's going to be less blood to the LV. Less blood to the LVs means less cardiac output, less blood pressure. And then that's going to reduce your coronary perfusion, which worsens RV ischemia. And then the less blood going to the left heart, you're going to keep overdistending the RV. And you can see it's just a feedback loop, and you keep spiraling and spiraling and spiraling until you end up at death, unless you can break that cycle. Here's another example as a way to look at it. As you have that increased RV afterload, you get that RV dilatation. You end up with tricuspid regurg. Additionally, because you have that over time, you're going to get RV hypertrophy. You're going to get decreased RV perfusion. That's going to lead to ischemia, which is going to worsen function. And so now you have RV ischemia. You have LV failure because you're not getting any blood to the LV. And then you have this severe tricuspid regurg, so blood's going backwards instead of forwards. So you can see how they quickly do poorly. RV dilatation, tricuspid regurg are two of the main things to look at. And then the shift of that interventricular septum. As that RV gets bigger and bigger, it's actually going to push that LV over. Now we're going to look at the echo, how important the echo is when trying to decide how to treat these patients. TAPSE. TAPSE is what's used to look at RV contractility. It's something that shows up in a lot of echoes, but you may not recognize it whenever you're reading through it. But it is tricuspid annular plane systolic excursion. And it's a fancy way of saying how much does that free wall of the RV move. Again, your LV is big and thick, and your RV is just a free wall that hangs out on the side of it. And because it has longitudinal fibers, is that it shortens. So if you're in the apical foreview, you'll actually see it shorten. And the more it shortens, the better the function. The less it shortens, the less the function. People may recognize McConnell's sign when dealing with massive PE is that the RV gets so much afterload so quickly is that that whole free wall just stops moving. The only thing that's moving is the apex, which is known as McConnell's sign, which is significant for a massive PE because the RV just isn't moving. So that free wall has to be able to shorten in order to push blood over to the LV. So anything greater than 2 centimeters is considered normal. Anything less than 1.7 is considered abnormal. As your RV is failing, as your RV dilates, your tricuspid valve doesn't grow with it. So as your RV dilates, it spreads apart your tricuspid valve. You end up with tricuspid regurg. The worse your tricuspid regurg, unless you have a intrinsic tricuspid valve issue, the worse your tricuspid regurg, the worse your RV function. And then you can actually determine that high afterload or that pulmonary hypertension on echo. And what we look at is that idea that says, all right, if your heart's trying to squeeze against high pressures in the pulmonary vasculature, is that the blood has to go somewhere, and so it ends up going backwards as tricuspid regurg velocity. The higher the tricuspid regurg velocity, the higher the pressure is on the right side, the higher the pressure is on the pulmonary vasculature to push forward. And so if you have very high tricuspid regurg velocities, it means that you have higher pulmonary pressures. Using the modified Bernoulli's equation, you can do 4V squared plus CVP, where V is your tricuspid regurg velocity in meters per second. So you do 4V squared, and then you add whatever you think the CVP is. And for a normal echo, when you look at it, if your IVC is less than 2 centimeters in variable, you would estimate a CVP of 5. If it's greater than 2 centimeters in variable, you would estimate a CVP of 10. And then it's greater than 2 centimeters non-variable, you would estimate a CVP of 15. So you would add that on to that 4V squared. If that number is greater than 40, then that means they have a very high probability of having pulmonary hypertension. Now, if you read the European guidelines, they don't use modified Bernoulli. They only look at what the tricuspid regurg velocity is. And if it's greater than 2.8 meters per second, then that is also significant for pulmonary hypertension. Here's an example of called a D sign. This is in the parasternal short view. This is what I was talking about with that interventricular septal shift. The RV is so big at this point is that it's pushing that septum over. It's flattening that septum. It's making the left ventricle, which is big and thick and usually looks like an O, and flatten it out so it looks like a D, and it's called a D sign. If it is flat only during systole, then it is most likely a pressure problem. If it's flat only during diastole, it's more of a volume problem. And if it's flat throughout the cycle, then it would be a pressure and volume problem. You can think about this as almost like pericardial compartment syndrome. Your pericardium is a fixed space. It can only really have so much in there. We've seen it with tamponade. Whenever you get blood between the pericardium and the heart, is that it's going to compress. This is the same thing, where you have the RV just keeps dilating and dilating, but it doesn't have any room to grow, so it ends up pushing on that left ventricle. By pushing on that left ventricle is that it actually gives the left ventricle diastolic dysfunction. The left ventricle can't relax, it can't let blood in because it's being pushed so much by the right ventricle. And so you end up with this kind of big RV, tiny LV with this D sign. And in fact, you can get pulmonary edema from right heart failure. It's not very common. It's a sign of severe right heart failure to the point that you've pushed that septum so far over to the LV that it's not getting good filling. And by not getting good filling, it's causing pulmonary edema. So again, it is rare, but you can actually get pulmonary edema from right heart failure because of it pushing so much on the left heart. And now we're going to get into treating right heart problems. What can we do once we identify somebody with right heart failure? I'm not going to talk about the elevated preload. Again, it's not super common in adults. And the primary problem is just a lot of volume. You can work on that. And if you have decreased contractility, typically it's due to an RV infarct. So you either want to give thrombolytics, or you want to go ahead and take them to the cath lab and look at doing a cath with a possible PCI. That's how you're going to be able to open that up and improve that part of it on things. I am going to talk about elevated afterload because those are the ones where you really can do more medical management on things, and you're going to see it a lot in the ICU. This is a great paper, came out in 2014. It talks about the management of acute right heart failure. It goes into all the physiology that I've talked about, but it also gives you a really nice algorithm that says, hey, just follow this algorithm. This should really help you out whenever you're doing it. So the first thing it says, all right, you've identified somebody as having acute right heart failure. Is it a treatable cause? Is there a PE that you can quickly treat? Is there an RV infarct that you can quickly treat? If not, then the first question they ask is excessive preload. And again, think back to what a lot of people are being taught. This is the RV likes preload, give them preload. Oh, the RV's failing, give them volume. Is that the first thing it asks is there excessive preload? The RV, if it's not doing well because of not enough contractility or too much afterload, it does not like preload. It quickly gets overdistended, it quickly gets severe tricuspid regurg, and then it ends up spiraling. So you really want to shrink that RV down, get it back on the right part of the Starling curve so that you can really get that RV to work and improve. And so the first thing you want to focus on is, do you think they have too much preload? And if you do, you either want to start on diuresis or start them on ultrafiltration with some sort of, usually CRRT. Here's some myths that we kind of talked about. The idea that right heart failure patients like a higher CVP. I hear that all the time. Oh, the right heart's not working. Get their CVP up to 18 or 20 or these really, really high numbers. And in fact, that's just not the case. It can actually worsen it and make things significantly worse going forward. And so I want to introduce the idea of renal venous congestion and also organ congestion and pulsatility. They kind of have, they're related but somewhat different with it. So the first thing we're going to talk about is the myth, this whole idea that a higher CVP is important. So this is the pressure volume loop whenever you're looking at the right heart, it looks very different from the more squared out pressure volume loop of the LV. And that's because there is no isovolumetric contraction or isovolumetric relaxation. Is that it's filling during diastole, it's filling during systole, is that it just is different from an RCA standpoint, it's different in an RV standpoint as you get this more triangular pressure volume loop. If you have RV dysfunction and chronic RV failure over time and you get this hypertrophy, is that you end up with this, you almost starts to look like that LV loop. You see it kind of square out and you start seeing that isovolumetric contraction and relaxation. And then as you go into RV decompensation, you slide up the curve that you see here. And so as you get in decompensation, you'll see them slide up on that curve and go higher up. That doesn't mean that they want to be there or like to be there. It just usually means that they have higher pressures because they're in decompensation. They're not pushing that blood over to the right heart, and because they're not pushing that blood over to the left heart, and because they're not pushing that blood over the left heart, it's building up, and so you're seeing that elevated pressure in the RV. Same thing with a contractility issue, is that if you can't push that blood over the left heart, it's going to build up and you're going to get higher pressures. You're going to end up decompensated. That doesn't mean they want to be there. It's just people with right heart failure are going to have higher CVPs because they're getting decompensated. And so you want to focus on kind of correcting them. Renal venous congestion. This I think is very important. I think a lot of people get mistreated because of a misunderstanding of what this is. But your kidneys have an afferent, a glomerulus, and an efferent, and then that creates this transglomerular gradient. You have this pressure drop across your glomerulus. The pressure in your afferent is different from the pressure in your efferent. This pressure drop puts pressure on the glomerulus. The pressure on the glomerulus causes a glomerular filtration rate, just like any filter that you have. The more pressure, the more filtering that you get. The less pressure, the less filtering that you get. And so what happens is that if patients get hypotensive, if they run into issues, hypovolemic, they'll say, they need more volume because our GFR is down, our creatinine's going up. We need to give them more fluid. And so the idea is that there's less volume getting to the afferent, so they drop that pressure gradient. That drop in pressure gradient drops that GFR. And yes, that does happen. It happens in people that are hypovolemic. It happens in heart failure patients. It happens in cirrhotic patients. It can happen in a lot of these patients. But a lot of these people, especially in the hospital, because they get so much fluid from everything they get, is they actually have a drop in that gradient, not because they're not getting good blood flow to the kidneys, but because they have so much renal venous congestion. That high renal venous congestion pushes that up, and then you have that same drop in gradient, but the drop in gradient isn't due to not having enough flow. It's just you have so much back pressure. You have this really, really high pressure. And so patients with right heart failure end up going into renal failure so quickly because they have so much back pressure, they're dropping that gradient. And if you look at heart failure patients, left or right heart failure, is that you have that high venous pressure when they're decompensated and they have decreased flow going to the kidney. So their gradient's even smaller than other people's, and they're so prone to going into acute kidney injury. So oftentimes you have to diurese them to drop that renal venous pressure, that renal venous congestion, and just trust the process. Say, hey, look, we've looked at them. They're volume overloaded. They have high venous pressures. We have to lower those venous pressures to improve that gradient across the glomerulus so we can start making urine. And even if the creatinine bumps a little bit, you just have to trust the process, keep diuresing aggressively, and you'll see that creatinine start to come down because you're improving that venous pressure, you're improving that Starling curve on the RV. Organ congestion and pulsatility. So the American Heart Association in their paper came out and they said the RV is not supposed to pulse. If the RV is pulsing over time, that leads to RV failure. So you need to focus on, am I at a state where we're having such bad congestion or RV dysfunction that it's pulsing? So how does it pulse? is as the RV stretches and that tricuspid valve stretches apart and you end up with tricuspid regurg, is that you actually start getting backflow, and such significant backflow that you get reversal of flow. So what we can actually look at is we can actually look at the flow or the Doppler flow through the hepatic vein or the portal vein or the renal vein, and we can look at that pulsatility. And if you see pulsatility, that is abnormal. You should not be seeing that. So in this example, we're going to look at the hepatic vein. So normally you should see basically the entire blood flow going from the liver to the right heart, like it should go with it. But as you start seeing people with RV dilatation, tricuspid regurg, is that you start seeing the blood flow start going above that yellow line. The blood flow above that yellow line is reversal of flow. So if you see reversal of flow, that means blood's going backwards when it should be going forward. And in the severe one, it actually has a sinusoidal wave pattern where every time during systole, all that blood's just shooting back up towards the liver. The same thing's happening in the kidney. And so you can see how over time this would lead to liver congestion and renal congestion, and they're going to end up with elevated transaminases. They're going to end up with acute kidney injury, all because they have all this backflow, and then you just have this pulsatile blood going up into the liver, up into the kidney, and then you have pulsatile blood returning to the RV. And over time is that this actually causes the RV to fail because it's not designed to deal with pulsatile flow. Here's the portal vein. So in the portal vein, it's the same type of thing. Whenever you do Doppler across it, it should be a nice straight line above the line. If you start seeing pulsatility of the portal vein, that means that you have reversal of flow, which is inappropriate or signs of severe congestion. This is best described in the Vexus criteria. So this has become really well looked at, and it works great to say, look, whatever we're looking at, I can tell you is that the RV is struggling because there is reversal of flow in the hepatic vein, there's pulsatile portal vein, there's pulsatility in the renal vein, there's severe congestion, there is too much volume on the right side. Now, if you have RV failure, then it could be that you're not necessarily hypervolemic, that you're just not getting blood from the right side to the left side. So you have to take it into context and say, all right, yes, I think there's too much volume on the venous side, and I think they're hypervolemic, or I think there's too much volume on the right side, but it's all because it can't get to the left side. I'm going to focus more on how can I get the blood from the right side to the left side. What it does mean, though, is that you should not be giving these people fluid. They do not need more fluid. They have so much fluid in their right heart that it's actually reversing backwards. And so you want to focus on either removing that fluid or trying to get that fluid from the right side to the left side. So if you see pulsatility, if you see that there's too much preload, you want to be aggressive in either starting diuresis or just go ahead and doing ultrafiltration. I have a very low threshold to go ahead and start people on CRT if they're in RV failure, because getting that volume off matters so significantly, and that you waste time because they're so sensitive to getting acute kidney injuries, is that you'll spend 24, 48 hours trying to get them to make enough urine, and then they're only getting 300, 500 cc's negative, and they're not getting the amount of volume off that you need whenever you could easily put in a Bass cath and be able to do CRT and remove a lot of fluid. So next we're going to talk about afterload. So the first part of afterload is correct those things that we talked about before. Is there anything from a systemic problem that we can do to correct them? Can we fix their hypoxia? Can we fix their acidosis? If we can, it's going to go a long way to help out with that pulmonary vascular resistance and reducing that afterload. Do they have abnormal lung volumes? Right? Do they need to be, do they need positive pressure to fix atelectasis? Do they need to come down on their positive pressure to reduce overdistension? It's just paying attention to the lung volumes whenever you're trying to reduce their high afterload. If you can't fix systemic problems, or you fix the systemic problems and they still have signs of high afterload, then you can start thinking about pulmonary artery dilators. There's many different classes. There's your endothelin receptor antagonists, your phosphodiesterase inhibitors, your prostacyclin derivatives, your guanylate cyclase stimulators. We typically in the ICU use inhaled epoprostenol, or we could use inhaled nitric oxide. I like to use inhaled. The reason I like to use inhaled is because in theory, you're only dilating capillaries that are attached to alveoli that are working. And so you're improving that VQ matching. You're not necessarily dilating all of them. If you were to give like a systemic pulmonary vasodilator, then you're going to send all that, you're going to dilate everything. And if you have arteries that are not attached to alveoli because of shunting atelectasis, is you can actually worsen shunting because you're dilating everything. Whereas in the inhaled, in theory, you're only dilating ones attached to alveoli. It also causes a lot less systemic hypotension, and so it's much more tolerated in the ICU. And then, so inhaled epoprostenol is easier and it's less expensive than the inhaled nitric oxide. Here's an example of the inhaled nitric oxide, but it's just going to be attached to your ventilator to be able to go in, and it's going to cause that vasodilatation. RV perfusion. I think this often gets overlooked. So again, we talked about that one of the big issues of them declining was they get this increased wall stress. It's a thin RV. It's not designed to handle a lot of pressure. So as you really stretch out that RV, it starts crushing that wall and crushing those capillaries and can lead to RV ischemia. And so I actually will do with a MAP push. We'll push to at least a MAP of 70, and that's going to help out with coronary perfusion. You have your MAP minus your CVP. So if you have this high CVP due to RV dysfunction, you do a little bit of a MAP push. That's going to help you feel better to say that you're perfusing the RV. You're going to reduce that ischemia. People that have chronic RV dysfunction, they'll have a big, thick RV. And then, so if they have a big, thick RV that's having to work harder, then we also recommend a MAP push as well. So it just makes it easy. If you are in significant RV dysfunction, you should probably target a MAP of 70 or above. Here's different pulmonary vasopressors to be able to keep that MAP up. So phenylephrine should not be used. If you have any inclination that this person has high pulmonary vasculature, you should go ahead and remove phenylephrine from your list of drugs because it increases PVR. It just makes things worse. Whereas norepinephrine, it works. It improves the PA-RV coupling in animals that they've shown. It doesn't hurt it. This is one example where I actually use vasopressin first line. It's typically in septic shock. It's used second line. It's used as an adjunct with norepinephrine. In this situation, I'll actually use it as a primary because at these low doses that we use in our septic shock, 0.03, 0.04, is that it actually causes pulmonary vasodilatation. It increases arginine stores, which increases nitric oxide production, and it lowers your pulmonary vascular resistance while it's increasing systemic vascular resistance. So it's doing everything that you want. It's raising the MAP, your systemic blood pressure, while it's lowering that pulmonary pressure so that you can get better right to left flow. So I always put vasopressin on first, and then I'll add norepinephrine if I still need more vasopressors to improve MAP. Now, RV contractility that we talked about, if they're having that poor TAPSE, if we're seeing signs of poor RV contractility, then we can start talking about inotropes. So dopamine is out. We learned in the SOAP2 trial that it worsened outcomes in a subset analysis. It just leads to arrhythmias. It's not something that you really want to be using. Dobutamine and milrinone are going to be more commonly used. Milrinone would be the ideal one if you can get away with it because it is a phosphodiesterase inhibitor. It will lower pulmonary vascular resistance, but it does also lower your systemic vascular resistance. So it can cause too much hypotension. They may not be able to tolerate it. I always go to milrinone first. It does have a longer half-life, so if you do run into trouble, it takes a while to get back off. But the benefits of milrinone with increasing contractility while lowering afterload really make it the ideal drug for the right heart if they can tolerate it. So like milrinone and vasopressin as a combination works really well. And then if you've done all these types of things and they still are in RV failure, then you need to start considering mechanical support. So either ECMO, or an RP and Pella if you think it's due to RV contractility issues, a Protect Duo, something that's going to either bypass the right heart or something that's going to augment the right heart so that you can get it across. If it's due to high afterload, you're not going to get as much benefit from these ones that bypass the RV because it's not a contractility issue, it's a pressure issue. And so unless you're doing something to really lower that pulmonary vascular pressure, increasing the amount of flow that's going to it isn't necessarily going to help you out. Here's some rescue devices. This is ones we talked about. The balloon pump, even though it's put on the left side, has been shown to show some benefit in RV dysfunction, so it's something to keep in mind. An RVAD can be used, or a right ventricular assist device. VA ECMO works great because even if it's an RV contractility or a pulmonary pressure problem, is that you're taking that blood from the venous side, you're sticking it on the arterial side, so you're completely bypassing both of those problems. I think the big thing is if you find something that works and we've started the treatment and we say, hey, we've done this treatment, what can we do to improve? Or how are we knowing that what we're doing is improving the patient? Is that we can monitor for response. And by monitoring the response, we can say, all right, we've done this, they're getting better, let's continue down this path, or let's go to do something different or add something to it. So you can do invasive monitoring. You can do a pulmonary artery catheter, you can do a central line, you can monitor things like with the pulmonary artery catheter, you can monitor your PA pressures, your CVP, you can monitor your mixed venous, your cardiac output. With a central line, you can monitor CVP, you can do central venous. These are all things you can do. You can argue positive and negatives with them, but you can at least see trends with them and see if that's helpful. But I like to say this is a great example where you can really use echo or ultrasound to show that you've improved this patient. So if we remember from this figure is that if you're going to see RV dilatation, you're going to see tricuspid regurg, you're going to see that shift of the interventricular septum. These are all signs that you're having RV dysfunction. And so as you improve them, you should see reduction in RV dilatation, reduction in tricuspid regurg, reduction in that shift of interventricular septum. And so here's what it would look like is you have that tricuspid regurg, you have that septal flattening, you have that reduced TAPSE, is that if you've removed volume, if you've started inotropes, you should maybe see that tricuspid regurg go from severe to moderate. You should see that septal flattening start to lessen and start looking more of an O instead of a D. You should see that TAPSE improve and see that number get bigger because you're making the RV better on the Starling curve by increasing contractility, reducing volume, making it easier for the blood to go from the right side to the left side by reducing pulmonary vascular pressure problems. The last thing I want to talk about is preventing right heart failure. I think if we can just never get to this point, that would make a big difference because then you don't have to deal with this problem that has such a high mortality rate. And so by saying, oh, this person's at increased risk for pulmonary hypertension, I'm going to go ahead and identify them, try to do an intervention so we don't get from that point where the pulmonary hypertension worsens to the point of RV failure. So there's chronic pulmonary hypertension. That's going to be gradually elevating pulmonary pressures. The new guidelines have actually lowered this PA pressure to just be greater than 20. And then our RV failure course is that you get this RV dilates, and then as it dilates, you get the tricuspid regurg, you get the venous system congestion that we talked about. But whenever you get that RV failure where it dilates to the point that you're now in failure, it's so late that you want to catch it where it's just dilated, where you just see the tricuspid regurg. If you catch it there and start doing things to help prevent or reverse this problem, then you can avoid the RV failure. Once you've gotten to RV failure due to pulmonary hypertension, you're so late in the course, their mortality is super high. It makes it a lot harder to treat these people. So venous system congestion, we've talked about it, but you have all this back pressure. It leads to CKD. It leads to lower extremity edema. It leads to like cardiac cirrhosis just from all this back pressure. And so very much chicken or the egg. People that have cirrhosis and portal hypertension get pulmonary hypertension. People that have pulmonary hypertension will eventually get cirrhosis from this chronic congestion. Same thing is true with CKD. It can cause CKD, and CKD can cause pulmonary hypertension, and they can build on each other. 50% of patients with obstructive sleep apnea end up having pulmonary hypertension. 2 out of every 3 people with advanced COPD. 60 to 70% of people with left-sided reduced function or diastolic dysfunction will have it. All patients, if they have mitral disease, if they have mitral regurg long enough, 100% of them will end up with pulmonary hypertension just because of the chronic backflow that happens with it. And then 40% of people with idiopathic pulmonary fibrosis. So it's more prevalent than maybe you realize, and then you're not going to know about it because it often gets written off. Oh, their OSA is worse, or oh, their COPD is worse, oh, their left heart failure is worse, when in fact, it's that they've now gotten pulmonary hypertension, they're starting to go into RV failure, and it's not being recognized. The new 2022 European guidelines talk about the diagnosis of pulmonary hypertension, and it says if you suspect that there is a cause, then you should go ahead and get an echo, and then that echo will help look for signs of pulmonary hypertension. And those are the things that we talked about before. Do they have that high tricuspid regurg velocity that's going to make them have a high estimated pulmonary artery systolic pressure? So we're going to revisit these cases. We're going to look at what those cases were before and see if we maybe had missed something, or now that we understand it more, we can take a closer look. So this is case 1. This person, if we look at them, they have a history of diabetes, end-stage renal disease on hemodialysis. They have cirrhosis. They presented with altered mental status. They were admitted to the floor. They then decompensated, got more hypoxic, more hypotensive, lactic acid went to 11.4. They were given 2 liters of fluid, and they were worsened and transferred to the ICU. If you re-look at this, it says the RV is severely dilated. There is severe tricuspid regurg. Your RV to RA pressure gradient is 34. Your IVC is dilated with no inspiratory collapse. There is systolic septal flattening consistent with RV pressure overload. So yes, the LV cavity is small. Yes, the LV has a normal EF because it's hyperdynamic, because you have all this volume on the right side that's not getting to the left side. So you are in RV failure, most likely due to high afterload, because you can see the high RV to RA pressure gradient, and that it's just not being recognized. And so giving this person more fluid is going to worsen all that pressure on the right side. It's going to worsen that flattening, and it's going to cause even more flattening and worsening LV function. They're going to get more hypotensive and end up with a lot of problems. So this person was then started on milrinone, vasopressin, and inhaled epoprostenol. A VASCath was placed. They got started on CRT. We removed 6 liters on day 1. We then started on sildenafil to wean off the inhaled epoprostenol. Another 4 liters negative CRT. Day 3, they were able to come off the vasopressin, able to come off the milrinone. They tolerated IHD, and they were downgraded. So if you can imagine, if this patient was not admitted to a cardiac ICU and they were admitted to a medical ICU, and that maybe went unrecognized that they were in RV failure, and that they thought that they were just in septic shock and kept getting fluid and fluid and fluid, they may have decompensated to a point that they would not have recovered. So now we're going to look at case 2. Again, it says the EF is normal, 60%, but if you look, the RV is moderately dilated, decreased TAPSE. So you have this decreased RV function, the IVC is dilated. You actually have systolic flow reversal of the hepatic veins. So we're talking about reversibility. So you have all this volume on the right side, and your RVSP is 57 plus your estimated right atrial pressure. So you're looking at PA systolic pressures in probably the 70s. So they have severe pulmonary hypertension, and they have such dilated atria it's at a standstill. So this person had a history of hypertension, diabetes, and CKD. They presented hypothermic, hypotensive, and bradycardic. So immediately they were given 2 liters of fluid and started on dopamine and admitted to the ICU. You could see on that echo, if we look at it, is that they're not going to tolerate that fluid. They already have so much fluid on that right side that all that extra fluid is going to do is just cause complications because they have all this pulmonary hypertension. That blood's not getting from the right side to the left side. So if you keep just over-distending the RV and over-distending the RV, it'll get lower and lower. It'll keep going off the Starling curve and have worse and worse function. And so she decompensated on arrival after getting that fluid to the ICU and got intubated. The bedside echo was done. The TAPSE was 1.1. She was being actively warmed. The dopamine was switched to dobutamine. Vasopressin was added, and then a furosemide infusion. She immediately started making urine. She made 4 liters on day 1. She was warmed up. She was extubated. She was then weaned off the vasopressors and transferred out of the ICU. Again, is that if you're not paying attention to that echo, you may not recognize that there's this high pulmonary pressures, that they had all this RV dysfunction, that they were in RV failure due to high afterload, and you may consider that they're in severe septic shock or something along that line because they're hypothermic, they're hypotensive, they're showing signs that they're decompensating, but you may not recognize it's due to RV failure because the lungs didn't look overloaded. Case 3, you have somebody, they have a normal EF 60-65%. The left atrial volume is severely increased. So now you're thinking maybe there is a left-sided issue. There's moderate mitral regurg. There is entrainment of the blood, central dread of the MR. The right ventricular systolic pressure is elevated at 65 to 70. So again, you have a case where you have severe pulmonary hypertension. This severe pulmonary hypertension is probably related to the significant mitral regurg that they have. So she's 88 years old. She presents with dyspnea. Now, if you think and they say, hey, this person has significant mitral regurg and significant pulmonary hypertension, and you're worried about them being dysmic, is that the first thing I would think about would be, is their mitral regurg worsening? Do we need to do something that's going to improve their mitral regurg? Treating mitral regurg, you think about afterload reduction, reducing that systemic pressure, make the blood want to go forward instead of backwards. But if you don't recognize that on the echo, if you just look at the EF, is that you have somebody that has dyspnea that's hypotensive, and so obviously they get admitted for respiratory distress, treated for pneumonia, multi-lobar pneumonia, no fevers, no white count, just bilateral infiltrates and hypotensive, so treated for pneumonia. They send them home. They come back 2 days later. They're in respiratory distress again. They're given a dose of Lasix and sent home. They come back 2 days later. They end up in respiratory distress on BiPAP. Bilateral infiltrates again, bilateral pleural effusions. Again, they were treated for suspected multilobar pneumonia. Instead of recognizing that they had severe pulmonary hypertension, they had pretty significant mitral regurg. That's probably worse now between all the fluids that they've gotten from being in multilobar pneumonia. And they were admitted to the ICU on BiPAP. They were able to be weaned to high flow nasal cannula, and they were transferred out of the ICU. They then continued to get worse, probably from renal venous congestion. They then got 4 liters of fluid and then was intubated after that. If you could imagine somebody with that significant amount of mitral regurg getting all that fluid, they get intubated. They start getting treated for ARDS whenever it was most likely that they were just volume overloaded from all the fluid they'd gotten over the last week from being treated for multilobar pneumonia. Worsening respiratory, started on a Lasix drip, no urine output. They were prone and paralyzed. And it wasn't until day 7 that they were started on inhaled epoprostenol and their oxygenation improved. But by that time, the family says, she's been through enough, and they were able to do comfort measures after a family meeting. Now, if you just think about how things maybe would have been different if they'd have recognized the echo and said, hey, they have pulmonary hypertension, they have this severe moderate to severe mitral regurg, is that they're going to need something different than just fluid and being treated for pneumonia. They never had a cardiology or heart failure consult, and then pulmonary hypertension wasn't even documented as a problem until day 6. So it is so unrecognized, pulmonary hypertension, and RV failure is so unrecognized. Is that just pay attention to the echo, look for it. If you identify it, it doesn't always mean that you can start a pulmonary vasodilator. In this case, the problem was the left heart, so you actually don't want to start a pulmonary vasodilator, but just recognizing that they're not going to tolerate all that fluid, that they need a hemodynamic change, not just more fluid whenever they start getting into trouble. And then case 4, this is a patient that has LVH. They have a normal EF. They have grade 2 diastolic dysfunction. Their RV systolic is normal, but if you look, the RVSP is estimated at 50. So you already have signs that they probably have pulmonary hypertension. So while the RV is not failing currently, they have only mild tricuspid regurg, mild aortic regurg. they have elevated right ventricular systolic pressures. So this would be the person that says, hey, I want to know why they have this elevated right ventricular systolic pressure. I want to go a little bit further and just see if there's something that we can prevent them from going into chronic pulmonary hypertension and then a higher risk for right heart failure. So know when to refer. So if you go and look at these pulmonary hypertension guidelines, as they say, all right, you have this elevated tricuspid regurg velocity. What should they have? It would be greater than 2.8. Is then, do they have signs that they have RV failure? Do they have signs that their RV to LV ratio is high? Do they have signs that they have the septal flattening? Do they have signs that their TAPSE is down? Do they have signs that they have pulmonic regurg? Is their pulmonary artery diameter big? There's other signs on an echo that can show it that'll say, hey, this person's at higher risk than the person next to them. So just make sure you're identifying these people and just do your due diligence to look at it, decide whether or not they're at higher risk so you can refer them to the people they need to be referred to. There's increased focus, I think, in the last couple of years on really looking at pulmonary hypertension and right heart failure. 2018, the American Heart Association did their statement on the evaluation and management of right-sided heart failure and really focused on a lot of the things I talked about. And then the new 2022 guidelines on the diagnosis and treatment of pulmonary hypertension. They lowered all the thresholds on when you can diagnose people with pulmonary hypertension. And so that way you can really make a difference and identify these people earlier. I would take home points. Just RV afterload and pulmonary hypertension problems is often ignored. Try to pay attention to see if they have them. If they have a D sign or a dilated IVC with pulsatility, that means they have a fluid or pressure problem. They don't need more fluid. They either need fluid off or they need something that's going to help their right heart get to the right side of blood get to the left side. If they have hepatic or renal pulsatility that's bad, you shouldn't just ignore it. You need to pay attention to it, figure what you can do to resolve it. Look for patients, if you're in clinic, look for patients that are at high risk for pulmonary hypertension and right heart failure. And then if they get identified on echo, consider referral to a pulmonary hypertension center if they meet criteria. Here's the references, and thank you very much.